Hi, my name is Isabella Kratzer. Thank you so much for taking the time to watch this pre-recorded session. I work at the University of Pittsburgh School of Medicine and UPMC, and I am here today to talk about some quality improvement work that I did while I was a trainee at that same institution. So this is Reproductive Health Needs and Perspectives of Psychiatric Patients, a Qualitative Needs Assessment. I have nothing to disclose. Here we have a brief overview of my talk today. I'll be providing some background and some context for our health system, as well as some qualitative research basics before getting into the specifics of this project. Our learning objectives here today are to understand the diverse reproductive health experiences of acutely ill psychiatric patients, to describe this particular sample's preferences and priorities for reproductive health services in the inpatient psychiatric setting, and to understand how this data can be used to support more robust services for this population, whether at our institution or at your own. As some background here, we know that individuals with psychiatric illness are more likely to experience difficulty connecting to routine health services, sexual violence, poor access to contraception, and unplanned pregnancy relative to their peers. So, for this project, we were wondering how we might be able to bridge this gap for our patients. In brainstorming possible interventions, we wondered whether we might be able to start a reproductive health service or a kind of consultation model for routine reproductive health needs within our freestanding psychiatric hospital. Just to give you some background for our health system here, at the University of Pittsburgh Medical Center's Western Psychiatric Hospital, or Western Psych, we staff about 200 inpatient beds at any given time, and we have units for general adult, geriatrics, child and adolescent, psychosis, eating disorders, autism and developmental disorders, and substance use disorders. Within Western Psych, we also have an embedded family medicine service made up of both physicians and APPs, and they provide support for our admitting psychiatric teams primarily on a consultation basis. Even before the start of this project, the family medicine service at our hospital was really excited about the prospect of potentially getting to provide this care for patients. So I did team up with them in order to do this needs assessment and evaluate patient interest in these kinds of reproductive health services at our hospital. For this needs assessment, I used qualitative research methods, obtained approval through our institution's QRC, and then I interviewed patients who were admitted to Western Psychiatric Hospital's inpatient units. And through those interviews, I assessed reproductive health needs and perspectives of those patients. So I want to provide a little bit of background on qualitative research here because I think this is an unusual format for many of us. For qualitative research, we typically use an open-ended field guide for the purpose of conducting semi-structured interviews with participants. This guide can evolve over time, adding or subtracting various questions, and it is really a basic framework. We allow participants to explore various aspects of the topic in a relatively free-flowing way. Interviews are then conducted until we reach what's called thematic saturation, which essentially means that any new participant that we bring into the sample is not bringing up any new major themes. Once you've reached thematic saturation, that is when you can end your sampling. Interviews are then transcribed and coded for themes and content. And in qualitative research, we report on dominant themes, not necessarily on specific numbers or percentages. This is because, given the flexible nature of the field guide and of the interviews themselves, we might not actually be asking all patients the same questions. It's not that structured. So to say 70% of people thought this might not necessarily be true because we don't have a true denominator for that sample. This having been said, I will be including some numbers in this presentation because I know it helps many of us wrap our minds around the data that we're seeing. Just please do keep in mind the limitations of this reporting format for qualitative data. I've included here some screenshots of my actual field guide that I used in interviews for you to peruse if you are interested. The basic idea here is that the bolded questions are the ones that I wanted to get to, even if the interviews were difficult to redirect. But as some background for the rest of the presentation, I talked with folks about reproductive health, about their experiences with pregnancy and birth control, and then I pitched this idea that we might be able to start a reproductive health service embedded within the psychiatric hospital, that this might provide some kind of birth control, perhaps pap smears, perhaps access to other kinds of STI testing, and what would they think about this? Here is the next page of that field guide, and the last here. Most of the interviews I conducted for this project were about 20 minutes long. I transcribed them myself based off of recordings I took at the time and coded the data manually for common themes and common content between the interviews. For recruiting patients into this project, I was looking for individuals age 18 to 50 from our higher and lower acuity general adult psychosis and dual diagnosis units at our hospital, folks who had a uterus, who were not known to have reached menopause, who had no known intellectual disability, and hopefully whose serious mental illness symptoms were not particularly worse than they are within the community. So for that SMI population nearing discharge. Now for the results of the needs assessment. For this project, I ended up interviewing 10 patients before we reached thematic saturation, so it was a relatively small sample. The average age of the participants was about 35 years old. Age range was 21 to 44. It was a mostly white sample. And then these diagnoses at the bottom are self reports by the patients on the handwritten demographic sheet that I gave them at the beginning of the interviews. So I did not have access to folks' medical records. I could not corroborate this in the medical record. But my sense was that we had a pretty good cross section of the diagnoses that we tend to treat at our psychiatric hospital. This is also self-reported data from our demographic sheet. What I wanted to point out here is that at the time of the interviews, essentially nobody wanted to become pregnant. The one person who said that she did later clarified that she was no longer trying. And despite this, very few people actually reported that they had recently been using any form of contraception. Of the participants who did report using some form of contraception recently, the methods were either not particularly effective or methods where you need to be really consistent about the use in order for them to be reliable and effective. And I bring this up because I think many of us would hope for our patient population that they have access to more reliable or easier to use forms of contraception if they don't want to become pregnant. Results. So, of the 10 people that I talked to, 7 had been pregnant at some point in the past. 4 of those 7 people had actually had teen pregnancies, which I thought was a pretty high proportion. 2 of them had had a pregnancy loss or a stillbirth, and 2 reported prior abortions. So, some dominant themes here. I asked every patient that I interviewed about the interaction between mental health and reproductive health and what they thought about that. Many people said that there was some aspect of reproductive health that could negatively affect mental health. So things like menopause, the menstrual cycle, birth control use, STIs, the postpartum. Many people said that mental health issues can lead to poor self care, which can affect your attention to reproductive health needs or otherwise have some negative impact on your health overall. Several people said that mental health can negatively affect pregnancy or conception. And then several people said that mental health issues might indicate that you're not necessarily in a great place psychiatrically to become a parent at that time, and that maybe that is relevant as well. Every person that I talked to thought that offering birth control, contraception, long acting reversible contraception at our psychiatric hospital was a good idea. 80% of the folks that I talked to independently volunteered this idea that there was some aspect of the Western psych inpatient population that made in hospital access to these services even more crucial. This is not something that I asked people. It was information that they brought up on their own. Many people talked about the perceived gender or age breakdown on the units, but some people also brought up this idea that people in the hospital are acutely ill and maybe we should be making it easier for them to access these services. This is one patient quote. Because we're not just talking about people in the hospital in general. We're talking about people with mental health issues a lot of the times. I know that I personally struggle to take care of myself right now, so I'm not interested in having children right now because the idea of having to take care of another person when I can barely take care of myself, that matters. Every person that I talked to also reported that they would feel comfortable saying no to reproductive health services offered to them during a psychiatric admission if they didn't want them. This is another thing that I made sure I asked everybody. I actually had an explicit conversation with all of the participants about the history of eugenics and psychiatry, and wanting to ensure that people felt that they could freely consent to or decline these services, even if they were offered to them within an acute facility for psychiatric treatment. These were challenging conversations. A lot of folks had actually never heard of eugenics before, but I think it was important that we got this data from them. Now, unfortunately, this was a question that I added a few interviews into the samples, so I did not actually get to ask everybody about this, but most of the participants that I talked to were in favor of the family medicine service at our hospital offering medication abortions to patients who were admitted. Another patient quote here. It's just that I am very angry, and I believe it is our right to choose, and I understand that if you are against abortion, do not have one. Some more dominant themes. More than half of the people that I talked to reported that they would likely utilize these reproductive health services if offered to them during a psychiatric admission. Following this needs assessment, Western Psych's embedded family medicine service has started taking reproductive health consults. Within these reproductive health consults, we are working on providing expanded STI testing options, so things that might require an exam rather than just serologies or urine testing. We are working on expanding access to contraception initiation and contraception counseling across our floors at the hospital. We are working on cancer screening options. We're hoping to be able to do in-house pap smears and maybe even get people connected with and scheduled for mammography if they are not up to date. And then we are also working on seeing if we can provide some expanded family planning options in-house as well. Now for some strengths of this project. Based on our literature search, we do think that this was novel content. It highlights perspectives of a vulnerable patient population on an increasingly vulnerable aspect of healthcare, particularly in today's political climate. And it also reinforces that our patients can have these complex conversations even when they are acutely psychiatrically ill. And I bring this up because some folks that I have discussed this work with have seemed surprised that our acutely ill patient population, particularly those with psychosis or perhaps mania, would be able to have really challenging, nuanced discussions about these topics. And I am here to say that they absolutely can. And really, I had some very interesting and at times difficult conversations with people during this work. And I would very much encourage you to have these conversations with your patients if you think that they would benefit from them. In terms of limitations, this was a small sample size despite having sampled to thematic saturation. And I think that there are a couple of reasons why this might be the case. I think that there might have been some selection bias in terms of psychiatric pathology. I did have to record these interviews in order to be able to process the data, and that is a very unappealing prospect to most individuals with active psychosis. Additionally, I warned people that I wanted to talk about reproductive health topics, and I think based on people's reactions to this, that this was a pretty clearly unappealing topic of conversation for many people who I tried to enroll in the project. So I think that that's potentially another form of bias here. So, in terms of future directions for this work, we are currently working with our in house family medicine service on building out the reproductive health services that we have available to patients admitted at our hospital. I have been spreading the word on these new services through various departmental avenues, including departmental grand rounds and other platforms. And then we have been working with our in house pharmacy department on the financial viability of doing things like IUD placements during a psychiatric admission. This is unexpectedly a pretty challenging issue in terms of expenses. And so we're trying to work that out right now. We are also gathering data on the utilization of this service in general. So I have been tracking reproductive health consults that have been placed to family medicine and trying to follow the topics that have been discussed in these consults. This has also proved challenging because many teams will often consult our family medicine service for a variety of medical issues at once. And so parsing out what does and does not qualify as a reproductive health consult has been difficult, but we're working on that. In conclusion, our acutely ill psychiatric population has diverse reproductive health experiences and needs. Our patient population is very much capable of having these challenging and nuanced discussions around these topics. So if you feel that folks could benefit from these conversations, please do initiate them. And I hope that we can use this data to build out these much needed services for our acutely ill patient populations, whether that is at our institution or yours, in the inpatient medical setting or the inpatient psychiatric setting. I think anything that can expand the availability of these services for folks would be really hugely appreciated. So unfortunately, I'm not able to be there in person right now, but if you have any questions about this work, please feel free to email me at the email address here, and is also on the next slide. Finally, I want to say thank you so much to my collaborators on this project. I had great support from the Department of Psychiatry and Family Medicine, as well as a qualitative research expert from our Department of Obstetrics, and I could not have accomplished this project without them. Additionally, thank you so much to the entire Family Medicine Department for actually providing this important patient care once we were able to demonstrate our patients' interest in it. And here are my references. Thank you so much for spending the time to listen to this presentation today.